Okay, Assalamu alaikum and good evening and welcome to the Conceptual Basis of Urology course. And today we are discussing urodynamics. I know as an examiner and interacting with the colleagues that urodynamics is not universally available in all institutions in Pakistan, and some of our trainees have very limited exposure to urodynamics. So we thought that it would be pertinent that we should talk about urodynamics. Today, we are going to specifically focus on urodynamics in women. There will be some cases which our Chief Resident, Dr. Yasser, will be presenting, and there would be discussion on those cases. Dr. Bajat Aziz, who is a consultant urologist at Aachen, will participate along with myself in that discussion. Following which, we are going to have a webinar or a presentation which was made in the European School of Urology EAU meeting last month in Milan. And with this, we are going to also offer all the participants of this course, if they wish to have any specific things, we can share the list of the topics of ESU courses, and we can run special sessions on ESU courses for the for our residents and trainees and consultants. So urodynamics is perhaps the only method for objectively assessing the function and dysfunction of the urinary tract. And we know that bladder is essentially an organ which is supposed to store and empty. And both these functions can be assessed by the urodynamics in an objective fashion. One of the simplest tests that we can do is uroflowmetry, along with estimation of the post-void residue. And it's a fairly commonly done test without which one should not diagnose bladder outlet obstruction, which we do mostly clinically. So this is one of the very essential tests that one should. Besides this, the other commonly done test is the filling cystometry, which is essentially looking at the bladder's ability to fill and how it reacts to filling. And that is probably the second most commonest test which is performed, although it has its deficiencies, lackings, but still it gives you a fairly good picture. Following which we have the detrusor leak point pressure estimation. This is not very commonly done and it has its flaws. Pressure flow study or voiding cystometry is the second test, which again assesses both the bladder functions, i.e. storage via filling and emptying via while the patient is micturating. So this is a very interesting test, and if you add video to it with the use of contrast, it adds a new dimension in the making of diagnosis of various conditions. It can determine the detrusor underactivity, detrusor acontractility, bladder outlet obstruction, the detrusor sphincter dyssynergia, high urethral resistance. And these are some of the things that can be assessed. Electromyography, which is not very frequently performed, has many problems, but it essentially looked at the skeletal muscles function, which are also important at the urethral sphincter, the external urethral sphincter, the striate muscle of the pelvis, the anal sphincter, and all that can be assessed with using electromyography. The urethral pressure profilometry, again, a little sophisticated test which requires additional equipment, is not routinely done, but this is another test that can actually, it has very limited value in urological disorders. However, it can assess obstruction. Video urodynamics and ambulatory urodynamics are the two things that we will be separately discussing in detail. So with this little background, I would invite Yasser Rashid, Chief Resident Urology in AKU, to present some interesting cases. So we see that how and when urodynamics are indicated and when should it be done. and what information we'd like to gather with these tests. So Yasser, you can share your presentation.
Thank you very much, Professor Ahmad. And is my screen visible?
Yeah. If you go onto the play mode, probably it will be, the full screen will be visible.
Okay. Is it visible at full screen now?
Yes, sir.
All right. So Dr. Ahmad has given a pretty comprehensive background on what urodynamics are indicated for. One of the most important things when we are going for urodynamics is to have a question in the mind about what we are going to look for. And based on that question, we can specifically look for things in the filling phase as well as the voiding phase of urodynamics. So with that, I will start with the first case. When we are doing these cases, I have with me Dr. Wajahat Aziz, and Dr. Hamad is also over here. So I would urge all the participants to keep sharing their thoughts and their ideas in the chat box, and we can keep addressing those as we move along so that we are all on the same page. The first case that I'm going to present here is that of a 27 years old female who's unmarried with no known comorbids. She presented with increased frequency, nocturia, urgency, and urge incontinence for a few months. And with that, recently she has developed refractory painful urinary retention. So some basic investigations done for her revealed that the ultrasound pelvis was showing normal kidneys and normal bladder without any pelvic lesions, and a residual volume of 350 ml was seen. Urine cultures were normal. Urine DR was also unremarkable. Her past history was unremarkable for any surgeries. Personal history suggested that she was unmarried, she was a student, and she had normal menstruation. General urological examination showed that the abdominal exam was normal, and DRE revealed normal anal tone. Grossly unremarkable neurological examination for this young female. So when we did urodynamics for this young lady, this is the filling phase. So if you just take one quick look at the filling phase, and this is a question for the participants, what is the most important thing or the most prominent thing you could see on the filling phase? What is one clear-cut diagnosis or clear-cut pathology that you can locate in this graph? So we have a few comments in the chat box. The pelvic examination was unremarkable. There's a question asked in the chat box.
No, yes, this is an important question because for ladies of any age group and especially young ladies, they do think of some pelvic lesion or pelvic malignancy, although this is not an age group for malignancies. But for young ladies, a pelvic examination is usually tricky. Most of the urologists who are male would not be comfortable doing a pelvic examination, and this young lady is unmarried. So all you can do is a digital rectal examination. So to rule out any pelvic pathology, an ultrasound of pelvis is at least mandatory.
Right.
So thank you, Dr. Nazim, for
pointing that out. So right, so we did the ultrasound, which showed that there was no pelvic lesion and the DRE was unremarkable. So we have some answers in the chat box, which have mentioned detrusor overactivity and involuntary detrusor contractions. Thank you, Dr. Wajahat, for pitching in, and I would request that as we move along, please keep pitching in the same manner.
So the appropriate terminology according to SIU is detrusor overactivity, also known as DOs. The overactive bladder or involuntary detrusor contraction, usually people mean the same thing by that, but the appropriate terminology is detrusor overactivity.
Right, thank you. So if you look at this screen, we have a lot of information over here. And some of the few things that we look for in the filling phase are if there is appropriate or how's the bladder capacity, what is the compliance like, how are the sensations if they are being felt at the normal or appropriate intervals, if the bladder is stable, if there are any detrusor overactivity that can be seen, and also if there is any leakage. So these are some of the things that can be seen in the information over here. We can see that as we progress in the filling phase, there are some detrusor overactivity that can be seen. The abdominal pressure is fairly constant throughout the examination in the filling phase. We can also see that the sensations are mentioned over here as first sensation being on 293, and the desire to void is right afterwards at 294 ml, and a strong desire is felt at around 296. Maximum capacities around 297 for this patient. Then at the in the middle of the slide, you can see that the total infused volume is 513, whereas the volume lost through leakage is around 213, and only 300 ml could be retained over here. Anyone would like to comment on this? What information can we gather from the volume lost through leakage and what is left behind?
So there are some questions about what is the volume lost through the leakage. So it is given to 213 ml, roughly out of 500 ml, 200 is lost and 300. And then about the bladder capacity. The total bladder capacity, physical bladder capacity may be higher, but your urodynamic bladder capacity would be 300 ml because you are unable to fill beyond this. The rest, it would either leak or the patient would unable to tolerate further filling. Maybe if you subject the same patient to cystoscopy, the original capacity may be higher, but the urodynamic capacity is roughly 300 ml.
Right.
One other important point that we need to see is that from the time of first sensation to the maximum cystometric capacity is more or less the same. So when she felt her first desire, that's the point that she could not hold any further. Only few mLs could further be infused. So clinically, this translates into urgency, and that's what typically these women complain. Did she complain of urgency, that she has to rush immediately when she has the first desire?
Yes, urgency as well as urgent continence at times.
Okay, so I think this is something which is important, and that finding is corroborated in the urodynamics. So clinical finding corroborated in urodynamics is a valid finding. That's an important lesson of urodynamics.
Another important thing that is important over here is that when we are doing urodynamics, not only the question that is clinically relevant should be in our mind, as well as when the urodynamics are actually being done, it's important for the clinician to be present over there or to have somebody who can answer all these appropriate questions, because just by looking at the graph, not everything is answered. We need certain information like when was the leakage there, when was the, at what time the patient felt that they could not hold any further, and leakages were there with cough or not. So all of these things are important with the filling phase. So with this, for this young lady, I would move to the voiding phase graph. So here it is now. So again, over to the audience, please have a good look at the graph. We have the results available as well, which are showing the Qmax as well as the pediatric Qmax for this patient. Voided volume is also seen. You can also see that the voiding graph, the UFM is there. The blue line is showing the vesical pressures. The red one is the abdominal pressures. The one in the turquoise is the detrusor pressures. On the third number, fourth one is the uroflowmetry graph over here.
There's a question whether the bladder was emptied before the study.
Absolutely. This is another important thing because when we are starting the urodynamics, it's one of the part of the urodynamics that not only bladder should be emptied, but that pressure, that volume should also be noticed at the post-void residual volume at the beginning of the study. So yes.
So this patient basically presented with refractory retention. So she already had a catheter in place.
Yeah.
So otherwise we would always empty it. Although there are some people who have suggested to do a urodynamic on top of the residual urine, because that is more suggestive of what is happening with the patient day to day, because he would start to fill on top of his PVR. But it is more appropriate to empty the bladder fill it and that take into the account of his PVR.
Right. So thank you for that comment. Would anyone like to comment on the detrusor pressures here? How are the detrusor pressures like for this patient? This is the third
Yes,
graph.
yes. Can you identify again the various graphs lines because it's not
The-
visible?
Right. The first one is the vesical pressures. The one in blue. The second one in red is abdominal. The third in the turquoise. The third graph is the detrusor pressures. And the fourth in the green one is the uroflowmetry curve or the voiding curve that we can see over here. So the third one, if we look at the turquoise line, the one showing the detrusor pressures, what do we infer from it? Are these good pressures? Are there no pressures at all? Is the patient able to generate some detrusor pressures?
So a good way to read would be there is a definite rise in detrusor pressure, quite significant, and despite that, she is unable to void it only few ml.
Okay, I've made it
And one
full
need to
screen now.
make sure that this rise in detrusor pressure is independent of any rise in abdominal pressure. So the red line, which is abdominal pressure, it stays at the baseline. So the bladder itself is exerting the pressure, and despite that, she is unable to void.
Right. So as Dr. Rafiullah has mentioned in the chat box, it's a fairly good detrusor pressure, but still, if you look at the Qmax, which is which is pretty low at this point. So, and a comment suggests that the patient has bladder outlet obstruction just by looking at these graphs. So,
One thing is that the pressure need to be even supranormal. For a normal person, if you have an obstruction, the pressure would exert a pressure which is normal than usual. The normal voiding pressure is roughly 30 centimeter of water or so. So usually the pressure should be higher than those.
right.
So in terms of the urodynamic conclusion or the language that ICS recommend, what would be the term used for this situation? Bladder outlet obstruction is a generic term, which she clinically also has and is being proven in the urodynamics study as well. But what specific bladder outlet obstruction? Bladder sphincter dyssynergia is something that we have not studied because you have to do urethral pressure studies as well. And then the typical graph in TSD is that there is very good pressure with absolute cessation of pressure and then again, whereas she has a very poor pressure, so very poor flow. So what we are seeing is high pressure or normal pressure with poor flow. So high pressure, low flow system, which is what is correctly labeled as outlet obstruction.
Right. Right. So moving on to the reporting phase for this study, the assessments already mentioned over here is normal capacity, low compliance, normal sensations, severe detrusor overactivity at every 100 mLs with associated incontinence, high voiding pressures, poor flow with significant PVR. The diagnosis that many people have also suggested in the chat box, if the patient has DOs with urethral stenosis. So the question over here would be something that goes against urethral stenosis in history. Is there something that we can point out that does not correlate with urethral stenosis? Yes, somebody is, Dr. Nazim has mentioned in the chat box that the patient was catheterized not once but multiple times without any problems, and the catheter could be placed easily in a normal sized catheter. So at this point, this does lead us to other questions if the patient has some other form of obstruction that is leading to this. Dr. Vijay, would you like to comment on this? What
Yes.
should be the next plan of action at this point?
So urodynamics, the way it was done, that would only show bladder outlet obstruction. The potential cause, the only potential cause which you can identify at the time of urodynamics is about the sphincter activity. for that, somebody mentioned the urethral pressure profile. A more practical and useful way would be to EMG, electromyography. Urethral pressure profile would not be useful in noting the sphincter pressure throughout the voiding phase. It is more appropriate in looking at the leakage during the filling phase. So in that study, if you see at the top, there is an EMG electrodes, but probably they were not appropriately placed. So you can't make out because the whole black line. In a normal study, this black line should sort of shrink or disappear, showing that the sphincter has relaxed. And there are different ways of mentioning if there is continuous sphincter activity during the voiding phase. Some people would call it as urethral syndrome. Some people would label it as one type of detrusor sphincter dyssynergia, in which throughout the study there is continuous sphincter tone. The physical obstruction you can rule out either upon clinical basis, whether there was any difficulty during catheterization, or perform a urethral dilatation yourself either in the clinic or during cystoscopy. So for this patient, there was no physical obstruction based upon ease of catheterization, and the provisional diagnosis was some sort of sphincter dysfunction.
Right. And as you have mentioned, rightly so, that without EMG or UPP at this point, it would not be ideal to label her with some sort of a dysfunction of the sphincter. The treatment plans that were included were due to her detrusor activity, anticholinergics, as well as secondary neuromodulation. I'm very glad to see some of the comments in the chat box about CISC. Yes, she had significant PVR, and that would be the next thing that we could talk about. So for the other panelists over here, is CISC the only option in this case?
So one way of devising the treatment plan would be to look at the voiding phase as well as the storage phase. So if you put a patient simply on CIC, the problem she would have that she would leak on filling of every 150 ml or so, and every 3 to 4 hours she would have to do her CIC, because that would only sort the problem of not emptying the bladder. And on top of that, if the patient have high sphincter pressures, sometimes they have very much difficulty in doing CIC. So it's reasonable to add some sort of muscle relaxant to them. If not altogether abolish the problem, they would somewhat ease CIC, that's one. Secondly, you would need to add some antimuscarinics so as to increase the bladder capacity and address the urgent incontinence problem. So in the absence of anticholinergics, CIC would be sort of unmanageable.
Right. Is there any role of alpha blockers at this point?
I think the important question is that we need to see why this young woman has dysfunctional voiding. So this is, she has good detrusor pressure. She does not have any physical obstruction. So is there a functional obstruction? Does she have psychological reasons for this condition? Does she have, so a trial of alpha blocker is not a bad idea. And personally, I would prefer using a non-selective alpha blocker, which works better for women. So yes, that's one thing that can be considered. I agree with Mazhar's point that she should be on CISC until a definitive diagnosis is made.
Regarding the underlying cause, yes, Dr. Nazim also have mentioned that they should have a history of dysfunctional voiding since childhood and any psychiatric problems, if any. That sometimes the young patient become very anxious, and then in itself would cause enough sphincter problem. But for this lady, this history was absent. Otherwise, this happened all of a sudden in her late 20s. Otherwise, she was absolutely fine.
Right. Thank you very much for the comments. I think we can quickly move to another case before we can move to the
I think we have to do it quickly because we're short on time now.
Sure. So the second case is that of a 70-year-old lady, known diabetic, hypertensive, and known to have Parkinsonism. She presented with low urinary tract symptoms for about a year, mainly increased frequency with urgency and again urge incontinence. She also had poor flow at the same time. She was prescribed anticholinergics for her urgency and urge incontinence, and she was refractory to the anticholinergics. And she was also unable to do UFM when asked to do so. She was unable to hold urine long enough to do a uroflowmetry. Pelvic examination showed a reduced anal tone. There was no pelvic mass, and ultrasound was absolutely unremarkable. For this lady, when we took her for CMG, this is the voiding phase graph that can be seen over here. Sorry, this is the filling phase graph that can be seen over here, and the information about the filling is can be seen on the right side of the screen. So any comments from the participants about this filling phase?
So we have on the top the vesical pressure, the abdominal pressure with the red, and then we have detrusor pressure. The other two are not estimated, so you see a flat lines here. So can anyone tell us what is these spikes are in the initial phase? So Vijat, can you explain how to assess the placement of catheters and how to assess during urodynamics that
So-
we are?
Yes, so these spikes you ask at interval for the patient to cough. So you would see a rise both in vesical and abdominal pressure, but the detrusor pressure would be almost at the baseline. Also, if you see some artifacts, like if you see the second spike, usually what we do during your urodynamics to ask the patient to cough, because that would be a sort of a marker that it is an artifact, and also you can confirm that this artifact is not happening because of dislodgement of the catheter. The second spike, the patient was asked to cough because there was some artifact due to movement of the catheters.
Thank you. There are comments about the patient having a low compliant bladder. Dr. Vijay, what's your take on that?
So, sorry, low compliance.
Yeah, somebody has mentioned that.
The pressure is somewhat at the baseline up till 9. So you can actually calculate the compliance by dividing the change in pressure by the change in volume. So if you ignore the terminal spike, there is no definite rise in the detrusor, much rise in the detrusor pressure. So the compliance is somewhat normal. So if you divide 160 by 10, it would be roughly around 16.
So can anyone point out what are the two spikes that we can see towards the end of the filling phase at both the green line, which is the vesical pressure, and the detrusor pressure? There are some spikes that can be seen going up. Can any participants tell us what could this be? DOs, detrusor contraction. Somebody has labeled it as movement. Dr. Wajahat, if this was movement, what could be seen differently as compared to if this is detrusor overactivity?
So you can see that the abdominal pressure is at the baseline. Only the vesical pressure have increased. Also, someone has mentioned, what about the filling speed? So in these patients, what you usually have to do to repeat the study a couple of times, because during the first filling, they would not allow to fill much and would leak altogether. Then you start filling at a lower phase. Yes, for patient with Parkinsonism, we usually start with 30 ml per minute. And even if they are not able to tolerate, we would further reduce the filling speed.
Right. Thank you very much. So far we have seen that this is towards a lower capacity bladder with some detrusor overactivity that can be seen. Compliance is fairly okay with the pressures not increasing towards the end of study or even throughout the study. And we can appreciate that the cough reflex is showing us that the catheters were correctly placed. So if we move to the voiding phase in this same lady, who is a 70-year-old lady with Parkinsonism, and she was complaining of some urgency, urge incontinence, and some poor flow, just to remind you. And this is the voiding phase graph that can be seen over here. I'll try to zoom it in. Apologies for the slightly blurry lines over here. I'll just mention the top line is the vesical pressure. The second line is abdominal pressure. And the third one in the blue is showing the detrusor pressures again in this one. So would anyone like to comment? And the last one is the UFM, the uroflowmetry. It can be seen over here. Any comments about what's going on over here now?
Yeah, so you see that the detrusor pressure itself is roughly at the baseline, and this poor young old lady has tried somewhat with abdominal straining, and there is nothing more than that.
Right. We also see
So
that please
one
go ahead.
valid objection to this study would be why you have not filled it to beyond 150 ml. So that's what happens usually, that in these patients you are unable to fill beyond a few ml. They would either leak or would start to complain of too much pain. So have to be repeated a couple of times to make the diagnosis.
Right. So for the panelists, a term is very commonly used, which is neurogenic bladder. So would it be right to label this as neurogenic bladder? The participants can call it in the chat box, and the panelists can also comment on that.
I think that's an important point. This is a umbrella term that we use for a lot of lower urinary tract dysfunction for a lot of conditions. You can have neurogenic bladder, which means that the etiology of lower urinary tract dysfunction is because of some neurological issues. You can have a clinical picture of a neurological bladder, but without neurological causes. So it is something what you call as a non-neurogenic neurogenic bladder. So these are terminologies that you need to be very clear about. Some of these tracings can be used in the examination, particularly in the on-spot diagnosis, etc. So one need to be absolutely clear, and hopefully we'll try and cover it up with a little presentation in the ESU course that we are going to play just after this presentation.
Right. So thank you, Dr. Hamad. Moving on to the assessment for this patient. On the right, you can again see what are we looking for in the filling and the voiding phase, just as a reminder to the audience. This is a small capacity bladder. She had reduced sensations. The compliance was normal, and there was some terminal detrusor activity that we could see. In the voiding phase, we could see that there were low voiding pressures. There was poor flow with significant PVR that could be seen. As a diagnosis, it's a small capacity bladder with low voiding pressures. Can anyone suggest the treatment options for this lady? Minded, she's a 70-year-old lady and she's known to have Parkinsonism. She has poor flow and she has severe urgency and urge incontinence and small capacity bladder.
There are many suggestions, and they are valid suggestions. One question about the reduced sensation. It's important to see if the observation made in the urodynamic study is something which is duplicated in the clinical scenario as well. So if you do a non-interventional workup and it shows that, or frequency volume charting or an ultrasound, to show that she's able to hold 300 mLs, whereas during the urodynamic, she can only hold 100 ml. It typically means that this is the stress of the study and the study is not appropriate. And her actual capacity is 300 and not 100. Number one point. Number two, that Mazhar has rightly pointed out that you need to look at the clinical evaluation, the history and physical, and this is what we are going to show in the presentation that will follow, which is very important, and corroborate these findings with the urodynamics finding in order to objectively assess the dysfunction. So there's suggestions about use of anticholinergics or beta-3 agonist and so on. And I think these are valid because Parkinson's disease essentially does have overriding and cholinergic tone, and there is a disbalance between dopamine and acetylcholine, and that is the basic defect that you have. So anticholinergics have some role, but I think it is inadequate at the moment, the evaluation and the history to make definitive management plans.
To take it further, it also have management implications. Like in looking at the repeated PVR studies you have done and based upon bladder diaries, you can choose either between CIC versus suprapubic. Some of these patients would present that they would have some increased frequency. At times, they would have an increased PVR and even go into retention. And at times, they would be empty their bladder. So that type of patient usually do well if you teach them CIC, and somebody can manage even twice a day, later in the night and earlier in the morning. Sometimes you would be able to manage these patients. If most of the time the PVR is higher and they can't, and on bladder diary, you see that every time they are voiding not more than 100 ml or so, then probably they would be a candidate for suprapubic catheterization.
Right. Thank you very much for the comments. And with that, I think we should move to the presentation part. The second part.
Thank you very much, Yasser. Very nice cases and well presented. So with this, thank you very much and have a very good evening. The office.